In transplant surgery, the donor is much more important to us than the recipient. Kidney donors, we don't explain death as a complication because it's totally unacceptable to have a donor die. Removal of the kidney with an open incision is 1.5 feet incision, 18 inches.
Wow.
And removal of one rib. So you're creating a fracture and removing one rib to get access to the kidney. Diabetes is the commonest cause of kidney failure in India, and fast coming up as the second commonest cause is unfortunately Ayurvedic medicine.
Really?
Yeah.
So how has the treatment really evolved? You said that medical treatment takes care of 80% of cases,
Right.
and this has happened over the last maybe 15, 20 years, but it's still improving. So maybe you could just shed your light on the...
Surgical treatment for the prostate is one of the triumphs of modern medicine.
Okay.
It's the first genuine notes surgery. If you know what notes means, in capital NOTES,
Right.
it's the holy grail of surgery. It's
Maybe
what
you
we
want to
try
just
to
explain
do.
that?
Yeah, it's natural orifice transluminal endoscopic surgery.
Okay.
It's like the nostrils or the anal canal or the oral cavity or through the urethra.
Right.
So that way you leave no scar. You're using an existing natural passage in the body to do the surgery. And the most successful of these surgeries is TURP, transurethral resection of the prostate, which was introduced close to 90 years back in the United States.
Okay.
Yeah. And
So
really
almost a century ago.
Yeah, and became really popular around the late 40s, I think, 50s, and became standardized as the instruments and the optics and the visualization got better. And the last significant advance in this was in the regular TURP was in the 80s, the late 70s and 80s with a continuous resection resectoscope, which we use.
Right.
And since then, it's a very standard procedure the world over. In the early part of this century was the first new advance where instead of using regular monopolar current cautery, we started using bipolar cautery.
Okay.
And by that time, this was all the time being done with electric current. Now we have multiple lasers like the holmium laser, the thulium laser, the green light laser, and all these lasers which are used for this surgery. And these different energy sources have improved the surgery, reduced the bleeding, and added some safety.
I just going to ask you that. So the difference between monopole and bipolar would be the amount of the bleeding post-operative?
No, the biggest difference between monopolar and bipolar is the irrigant fluid used for the surgery.
Okay.
Because monopolar current requires a conduction fluid, you had to use water or glycine.
Right.
But bipolar you can do with saline.
Okay.
Now, water is a hypotonic solution as compared to the human blood.
Correct.
So when water goes into the blood as you're operating, it can cause hemolysis.
Right.
You can have the side effects of that, like what we used to call TUR syndrome, with low sodium, and patients could get critical with it.
Right.
With the bipolar, you're using normal saline.
Right.
So instead of giving IV, you're giving it from there.
Right.
So the anesthetist just gives a little less fluid, then during your surgery gets fluid.
Right.
So with laser and with bipolar, we do it with normal saline.
The side effects are significantly reduced.
Significantly reduced.
Okay.
Bleeding is much less with lasers.
Should a patient be asking these questions to a surgeon that, are you doing it by like a monopolar or bipolar technology, or today everything has moved to bipolar technology?
No, I think he should be asking this. Not everybody is still doing it.
Okay, so they should be aware and they should ask this question, are you doing monopolar or bipolar?
I think they should ask for a bipolar or laser. It makes a big difference.
So if a patient is affording and wants to do a robotic surgery for BPH, would you be okay with that even if it's a smaller prostate, or you would not recommend that?
So below, I would say 90 or 100 grams, I don't think it would be beneficial.
Okay.
But above 100 grams, it's a no-brainer.
Okay.
If I had a BPH, anywhere close to 100 grams,
then
I only want a robotic, nothing else.
Okay.
But I did a colleague of ours today,
but
we did laser for him. We didn't do robotic. It was 84 grams.
Okay. But fortunately, the need for surgery has come down significantly, right?
Oh, huge.
So you want to just talk about how the medical treatment for prostate has really evolved.
Yeah.
And how it has made a significant difference in outcomes.
There are 3 categories of drugs which we use for prostate now. One is alpha blockers. These are drugs which work on the smooth muscle in and around the bladder neck and the prostate, and they block the smooth muscle. They are similar to the drugs you take for blood pressure, which are antihypertensives, which block the smooth muscle in the vessel walls, and let the vessels dilate and
Right.
reduce the blood pressure.
Right.
Similarly, this smooth muscle dilates with these. It relaxes and
Right.
opens
Opens
the
up
area
the-
and allows them to pass urine better.
Right. Right.
These are the mainstay of medical treatment in BPH. When they initially came out in the late 80s and early 90s, they were not very selective. So they would also act on your blood pressure.
Oh, okay.
And we would get patients when we gave them a full dose of these drugs, actually sometimes get a heart attack also
Okay.
because the blood pressure would drop so much.
Right. Hypotension.
Yeah. Now we have super selective ones which act only on the
Smooth
alpha
muscle
blockers in the
of the prostate.
bladder and urethra.
Okay.
So these drugs significantly improve people's symptoms. And they are probably the reason why I would say prostate surgeries in a residency program have gone down by 90%.
Right.
Compared to when we were residents, they
But
are
as you
much
explained,
lower.
that the symptoms decide the treatment.
Yes.
So if somebody has obstructive symptoms, then is that the reason you would give alpha blockers, whereas somebody who has irritability symptoms?
Alpha blockers help for both obstructive
Okay.
and irritative symptoms. But in irritative symptoms, you can add one more class of drugs which work on the overactive bladder
Okay.
and cause some relaxation of the bladder and reduce the number of times they have to go to pass urine.
Okay.
These are called anti-muscarinic drugs.
Okay.
We never give these without an alpha blocker because
Okay.
they can cause retention of
So
urine.
alpha
Otherwise,
blocker is your mainstay.
is the mainstay, and
Okay.
then you have the anti-muscarinics which can be used for overactive bladder along with them. In
You
patients
also
with
mentioned
severe-
there are drugs now which reduce the size of the
Yes,
prostate.
that's the third variety of drugs,
Right.
and these are called 5-alpha reductase inhibitors,
Right.
5-ARIs. If you spoke to Sandeep last time, he would have spoken about using one of these for
Correct.
the hair,
Right.
and that also works for shrinking the prostate in a larger dose.
Okay.
So these drugs have limited benefits. They work if your prostate is larger than 50 grams. There's no benefit in taking them to below 50-gram prostate.
Okay.
And they don't work for beyond 6 months.
Okay.
You give them for 6 months, they'll act, they'll bring down the size of the prostate. They're unlikely to work beyond.
Right.
But for that 6 months, you can significantly bring down the size of the prostate to maybe 70% of what it was.
Right.
And that would give significant relief to the patient.
But alpha blockers you can give
Lifelong.
lifelong.
Yes.
Wow.
But again, BPH is a cyclical disease,
Right.
symptoms of BPH rather. And we find that patients need it 7 to 8 months a year. They don't need it throughout the year.
Oh.
Usually in the monsoon or in the winters,
Winters.
it's more because you tend to sweat less.
Okay.
And it's less in the summer when you sweat more and you're passing less urine.
So you give that option to the patient when you
I
know-
do, yes.
Okay.
I tell the patient to self-medicate sometime and
Okay.
choose. They can always stop the drug and see how they're feeling because it's a purely symptomatic treatment. It's not like a
Okay.
course.
Right.
The patient can take it and stop it as he wishes.
Okay. And in your experience, when somebody is on an alpha blocker, what is the incidence of them requiring surgery in the future?
There is no connection, unfortunately.
Okay.
The alpha blocker doesn't prevent you from getting surgery.
Okay.
It just makes you feel better. If you're feeling better with it, you don't need surgery. Like I said,
Right.
it's symptomatic treatment, right?
Symptomatic. Right.
But if your symptoms persist with an alpha blocker, or you get one of the concrete indications of surgery.
Right.
We have a few concrete indications. If you're repeatedly going to retention of urine and you need a catheter,
Right.
if you're repeatedly getting a urinary infection,
Right.
if you are getting blood in the urine
Sure.
because of BPH,
Right.
or if you form stones in the bladder, or dilatation or swelling of the kidneys because of your prostatic obstruction,
Right.
then you
Right.
probably need surgery regardless.
Okay.
Even if you say symptomatically, I'm okay, but you're getting an infection every 2 months,
Right.
then you need surgery.
And that forms about 20% of the
That 20% of the symptomatic.
symptomatic.
20% of patients will have symptoms, and 20% of those will need surgery.
Okay. Okay. So it's a very small
Very
percentage.
small percentage.
Oh, that's great. That's great. Now let's shift gears, to prostate cancer.
yeah.
What's been the incidence that you have seen? I mean, of course, with better screening, better awareness, maybe the number of cases also has gone up.
It's significantly up. I would say that when I started my practice 25 years back, I would be doing 4 or 5 radical prostates a year.
Okay.
Now we're up at 60 or 70.
Wow.
It's significantly up, and that's not only screening.
Right.
It's Western lifestyle, Western diet, increased fat in the food. All these
So you're
contribute to an
saying
increased
ultra processed food, lifestyle, your
Oh,
smoking,
hugely-
alcohol,
Oh,
all that.
Smoking and alcohol were always there,
Right.
and they would contribute. Not
Right.
alcohol, but smoking, yes, for
Right.
sure. I can't blame only a Western diet. I would say that genetically we are not conditioned to eat those diets
Sure.
because every community has evolved with a certain type of diet.
Sure.
And when you change that, that is when the problems begin.
Okay.
So all these issues are definitely there. That's what changes our.
So a statistic that said that 50% of cancers are actually lifestyle driven in some ways, actually a true
I'm
fact.
pretty sure, yeah. At least with prostate cancer, it's true for sure.
It is, okay.
Obesity is a risk factor, and diet is also a risk factor.
What is the role of doing a PSA test to pick up early,
For me,
cancer?
screening has a huge impact on early diagnosis and treatment of prostate cancer.
Right.
It's got a bad rap in the United States over the last 10, 15 years because
Correct.
they feel that there's over-treatment of people who would not have been found by screening. This is called lead time bias.
Right.
That you would find, suppose you feel that a guy is going to get diagnosed at the age of 85 and he wouldn't be treated for prostate cancer.
Okay.
If you're going to find his cancer because of screening at 65, you found it too early.
Oh.
He would have been okay not finding it at all.
Okay.
So that was one of the reasons they were saying.
Right.
But when prostate cancer screening was being done in the United States, after the screening started in the early 90s for 20 years, prostate cancer went from the leading cause of death in American men to 10th.
Okay.
And after they stopped the screening, it's climbing up the charts again.
Right.
So I think screening is not a bad thing. We screen patients who come to the OPD, but that's not genuine screening because these patients are coming with some symptom or other of urology. But I still think.
So as part of a routine health checkup,
I think
how often should
a
PSA?
Annual PSA.
After the age of?
45.
45. Okay. I always thought it was 50, but you're saying even.
I would say definitely 45 if you have family history.
Okay.
And maybe 50 without a family history.
Okay. Annual PSA.
Annual PSA.
Okay. And there's also something called
and a PSA done at 45 as a baseline.
Right.
If it's below 1,
right,
your chances of getting prostate cancer in your lifetime are low.
Okay. Okay. That's interesting.
Yeah, and it's not something that the reports ever tell you.
It's just experience that your
this
personal experience.
This is a published evidence. Yeah.
Okay. Okay. Understood. And there's also this whole concept of doing a rectal examination to see the size of the prostate or to know if the prostate.
So that's very subjective.
Okay.
There's a surgical aphorism which says if you don't put your finger in it, you put your foot in it. So we used to have this thing that you have to do a rectal examination.
Right.
Personally, with all the present day tools available to us, it's not essential to do a rectal examination.
Right.
I think it's still a good idea because there are some rare prostate cancers where the PSA doesn't go up.
Okay.
So we have a Venn diagram of, what's a Venn diagram?
Yeah, yeah.
So a Venn diagram of a DRE, which is a rectal examination,
right,
a PSA,
right,
and an ultrasound or an MRI, which
okay,
is radiological investigation, and they intersect somewhere.
Right.
So you would miss out a few patients if you didn't do a rectal examination.
Okay.
So it's probably a good idea to get a rectal examination once in a while.
So a PSA, a rectal examination, and a radiological imaging
test,
sort of completes the triad of screening.
100%, yeah.
Wonderful. Your experience on prostate cancers, I mean, how early do you pick them? Do you get, cases at an early stage?
I've been doing prostate cancer surgery. Prostate cancer surgery is a relatively new field. The first urologist to get a Nobel Prize, and still one of only 2 to get a Nobel Prize, got a Nobel Prize in the 60s.
Right.
For showing that removing the testes can control prostate cancer.
Okay.
The testosterone-driven cancer. And the early treatment for prostate cancer was just castration.
Castration, right.
And he got a Nobel Prize for showing this, Huggins. In the late 80s, Patrick Walsh from Johns Hopkins introduced a surgery called the radical prostatectomy, which remains the mainstay of surgical treatment for prostate cancer to this day.
Right.
And after he devised the surgery, which was an open surgery, we started having hope of curing patients with prostate cancer. They didn't need castration anymore.
Right.
With castration, you could control it for 2 or 3 years, but then it would go out of hand.
Okay.
But with surgery, you could cure them forever.
And you said cure, right?
Cure.
So you really mean that prostate cancer is one of those cancers that can be cured?
Completely cured. If you pick it up early, you can cure it for sure.
Okay. So as you just heard, prostate cancer is one of those diseases where you actually get a cure, and cure is not a very common term used in medical science. So PP, you want to just maybe share some light on this again, that what is the holistic treatment in prostate cancer that actually brings about this cure?
So we have multiple arms we can use. You have surgery,
right,
for a radical cure. Your radiotherapy for a radical cure. Your hormonal treatment, which has a lot of newer drugs,
right,
which work over the long term now. You have chemotherapy,
right,
which although minor still has a role to play in patients who are not responding to hormonal therapy.
Right.
And you have newer immunotherapeutic agents, which may also work in prostate cancer.
Okay.
And they're getting better and better.
Right.
This is the sort of cancer where we have so many approaches. Of course, it's a Western disease because Caucasians have it much more commonly than Asians or Asian.
Right.
And that's one of the reasons why there's so much research in it.
Right.
Because of that, you have a lot of armamentarium in your arsenal to treat this disease.
Right.
And if you take an overall approach, individualize the treatment to each patient, you can make sure that your patients are cured of prostate.
So this is important. You said because of the vast options available to you, you can actually personalize treatment based on the need of every individual. So, it's actually tailored to that person's needs.
100%. So, it's important to look at the patient, look at his age, look at his performance status,
right,
physically, and look at what he wants in future,
right,
to minimize the morbidity and maximize his lifespan, a comfortable lifespan. That's very, very important.
Right. Now, this is extremely reassuring that if you have a benign condition like benign prostatic hypertrophy, 80% or more of those cases can be treated medically. If you do adequate screening with PSA, you pick up prostate cancer early.
Yeah.
If you pick up prostate cancer early, you have as you said, an armamentarium of treatment options which can be personally tailored to the individual needs.
Absolutely.
To actually bring about cure. So there's a significant evolution in the way prostate disease is being managed.
For sure, yeah. It has changed a lot.
Amazing, amazing. And is the mainstay of your work now, as you said, robotic, where you do prostate surgeries and transplants, which are robotic? Maybe you want to just touch upon that?
So, robotic surgery has revolutionized prostate surgery. I'm one of the old school where I used to do laparoscopic prostatectomy,
right,
which was one of the most difficult operations anybody could do. But I have a huge experience having done more than 500 of these, and I've been doing it for 25 years.
Right.
Unfortunately, it's hard to train people in laparoscopy because there's a long apprenticeship period.
Right.
The learning curve has been significantly reduced with using robotics, and it's much easier to train my juniors to do robotic surgery.
Right.
And they can get outcomes similar to mine much earlier than they would have managed.
The learning curve is much steeper.
Open and laparoscopic radical prostatectomy is a very difficult operation, both.
Right.
But robotic radical prostatectomy is a much simpler operation than those two and easier for people to learn.
It brings me to an incident during our internship. I was at St. George Hospital assisting one of the registrars, and we were doing an open prostate surgery.
That's a simple prostate.
And I remember, after that, I had to keep pressure there for like 20 minutes, and I had to just sit there with just putting my pressure to prevent post-operative bleeding.
But that was simple prostate.
Yeah, I know.
Radical prostatectomy was way more difficult, and there were very few surgeons in India doing the open radical prostatectomy.
Right.
When we were interns, that surgery had not been invented.
Correct.
Yeah, it was invented later.
Great. And just to complete the triad of prostate conditions, I know the third condition may not be as prevalent, but prostatitis. What's been the incidence?
That's the commonest condition.
Which is the commonest between
the three?
Very
common, yeah. And in India, it's even more common.
Because people only speak about benign prostate hypertrophy or prostate cancer, but probably prostatitis does not get as much as the attention.
Unfortunately, prostatitis is extremely common in India. And extremely common in an urban setup like Mumbai, because you have a lot of double income families and a lack of exercise for the prostate for the male.
Right.
Because he hardly ever gets to see his wife. And your small apartments with the whole family staying together.
So you're saying lack of sexual activity is one of the commonest reasons.
So what exercises your prostate is the spurt of ejaculation that you get in semen.
Right.
Is actually the prostate contracting. And if you're not ejaculating regularly, it's hard to maintain your health of your prostate. And a congested prostate ends up with what we call prostatitis.
Right. And that you see is fairly common. So prostatitis, we mean infection or inflammation of the
prostate gland. Yeah.
Right.
We call it chronic prostatitis, or now there's an all-encompassing term called prostatodynia, which is prostatic pain. It's ill-defined. People will come complaining pain here, pain there. They're not sure where the pain is. And it's not easy to pinpoint pain from the prostate.
Right.
But it's very common in the age between 35 to 55.
Right.
And people who are busy starting off their careers and they don't have time for activity at home.
Right.
And this tends to create a lot
of...
You
see this in younger adults, in younger males.
In middle-aged men is the commonest.
Okay. And the treatment would be antibiotics?
You can't pinpoint that there's an infection. So antibiotics don't really work. We need to tell them to get a little more active,
Okay.
to have stuff which helps the prostate food-wise, lycopenes, food with lycopenes.
Okay.
That is fresh fruits, fresh vegetables, tomatoes.
Okay.
These are all good for prostatic health.
And maybe a controversial question or not, but will a masturbation be an alternative?
100%.
Okay.
I prescribe it to my patient
Okay.
because it's not always that you have a partner. So
Right. What is the future of prostate disease, and how do you see this evolving? I know you've been path breaking. You're a pioneer in so many areas. How do you see this moving forward?
I feel that prostate cancer probably will be managed medically in the future because the drugs are improving so rapidly.
Right. Right.
There's a high chance. In prostate cancer also, we have some indolent cancers which are low grade, we are high grade. The high grade, as of today, nothing other than surgery works.
Okay.
But I see drugs improving to a state where you probably, the surgery may go out completely.
So after you remove the prostate and it goes for a biopsy and the pathologist gives you a report, does the qualification in the report help you decide the type of treatment as well?
Yeah, two things are important: the pathology report after we remove the gland and the lymph nodes, and the PSA which is seen post-operative.
Okay.
So if we find a rising PSA, then we may have to give radiotherapy as an additional therapy.
Okay.
Or start hormones also for the patient, depending on what we see in the pathology.
Right.
It's not common, but we need to be prepared for it and tell all the patients that your real treatment will be decided 2 months after surgery when we see your PSA and we check out the pathology.
So, but the Gleason's grade on the report, is that an important aspect?
So the biopsy has already given you a Gleason grade.
Okay.
And the histopathology, usually it gets upgraded or downgraded, more likely upgraded.
Okay.
If you have a Gleason 7, it may become a Gleason 8 or a 9. But the higher the grade, then the more you have to watch out and the chances. This is where genetic testing can help to tell you whether there's a higher chance of a recurrence or a metastasis.
So this is
coming up in the future.
the importance of genetic testing. Okay. Post-operatively.
Post-operatively or even pre-operatively, somebody wants to know.
Okay. Okay. How often do you find you need to do a transrectal biopsy pre-operatively?
Always.
Always.
Transrectal or transperineal biopsy.
Okay.
So we have to do it to get a diagnosis.
Okay.
We would never do a major surgery for a patient without diagnosis of prostate.
Okay. Okay.
Our radiology colleagues keep trying to tell us, trust your MRIs, but I still like to have my biopsy.
So you need tissue diagnosis to plan surgery.
Any major surgery.
Right. Excellent. So benign prostate hypertrophy getting managed medically. You're saying prostate cancer also getting managed.
Yeah.
As a surgeon, does this make you a little uncomfortable, or gives you opportunities to explore other avenues?
I think that if a patient can get away without surgery, it's a triumph for the surgeon as well.
I always say a good doctor is when they're not needed.
Absolutely, yeah.
Yeah. I know consumption of healthcare as far as possible should be avoided, and if you can manage
for sure
easier ways, then better.
Exactly. My patients keep telling me, we hope we don't have to meet you too often professionally.
Absolutely. Absolutely. Now, this has been an amazing conversation. Any final message for the audience that you would like to share?
Oh, I think your setup here is fantastic, and it's a pleasure to do a talk like this.
No, I look forward to having, I think when people see this, I'm hoping we'll get more people keen to come and have a chat with me out here.
I'm sure they will. I'm sure they will.
No, great, PP. Thank you so much.
Yeah, it's been a pleasure.
Thank you, and wish you all the best, and keep doing the great work that you're doing. You make us truly proud.
Thank you. Thank you.
Great. Thank you.